This meeting is being recorded.
When there's questions, we can just pass the mic back and forth.
Oh, yeah. Do you want to have your own mic? I don't know. Sometimes maybe in all this technology, just unplug something inadvertently, but yeah.
Just if you need to, you know, from when it's time to do questions.
Just the housekeeping.
I gotta read a little waiver for this thing. So we can get funding.
So what?
So we can get funding, so we have to read this little thing in order to like get the funding.
Okay.
Huh? Unmuted. It's okay. They shouldn't. Okay.
And you're a med student,
I'm gonna pre-med.
pre-med? Where are you gonna go to med school?
Jobson is the goal.
Where?
Jobson.
No, med school here. Okay.
Yeah, I'm gonna start now. Okay. In support of improving patient care, this activity has been planned and implemented
I don't
by.
think people can hear you.
Yeah, I know.
In support of improving patient care, this activity has been planned and implemented by Hawaii Pacific Health and the John A. Burns School of Medicine. Hawaii Pacific Health is jointly accredited by the Accreditation Council for Continuing Medical Education, the Accreditation Council for Pharmacy Education, and the American Nurses Accreditation Career to provide continuing education for the healthcare team. To claim the continuing education credits, please note that you must. Oh, you have to complete the evaluation survey that will be emailed to you within 1 week of the offerings. Speakers cannot claim credit for their own presentations, and your continuing education credit will be immediately available upon completion of your evaluation. You get a fancy little cup.
Cool.
Yeah.
Oh, thank you.
Oh, thanks.
Nice. Cool. Can go on with my other leg. Yeah, I'm well laid.
Hi, everyone. So I believe we're still waiting for people to come in, but just wanted to get started. So a little background to this grant, this track is Department of Health received the Pediatric Mental Health Care Access Grant. It's a federal grant from HRSA, and one of the so this grant is based on or has had programs that have been ongoing for a while that we hope to follow, and its main focus is increasing access to mental health care for our keiki. And so we have Dr. Sandra Fritsch and Dr. Jeanne Van Cleave, who is a part of COPCAP, which is Colorado's Pediatric Psychiatry Consultation and Access Program. And they're gonna talk about their program, which is an established version of what we hope to accomplish in Hawaii as well. So we could get started. So if we could just get a round of applause for our guest speakers who came all the way from Colorado to be here.
Thank you. Is there a way to get the recipient list off? Can I just X it out? Cool. Thanks, everybody. We're both greatly appreciative of this invitation to be here to speak. It's an honor to be here, but also an opportunity to learn from each of you who's here so that we can share and partner together. Many thanks to Renzi Ballarin, who is the Hawaii Pediatric Mental Health Care Access Program Coordinator, representing the Hawaii Department of Health, Family Health Services. So please go visit her booth also, because she's got one. You know, our involvement here today started back maybe in late spring, early summer, long before what happened in Maui. And, you know, we can't begin without acknowledging the impact that what has happened in Maui will have and is already having on pediatric mental health, as well as the mental health of everyone there. You have all, each one of you, been experiencing trauma, and you know, the impact on historical legacies, the increased trauma to marginalized communities, and the impact on the healthcare workforce and the increased mental health care needs all around, in an area that is already underserved from pediatric behavioral health standpoint. I also want to acknowledge that pediatric primary care providers and primary care providers in general are right at the forefront of everything. I know a lot of work is being looked at for how retention can happen. We're experiencing people leaving regularly in Colorado as well, due to a lot of barriers, but to be at the forefront of something like the Maui fires and be a primary care provider in general can be really challenging. Anyway, I want to kind of move on. So we're going to talk about how COPCAP got started and some of the core bits of that. I'm going to start by talking about how it got formed, and Jeanne is going to talk about her experience as a pediatric primary care provider, but she's also on our evaluation team also, so she has a lot of other cool stuff to share as well. So we have to acknowledge that our program receives funding from HRSA. So this is just an acknowledgement of that. To be able to receive CME and CEU and whatever other continuing education credits, we have to have goals and objectives. So hopefully you'll learn about the current workforce challenges. You live it, you know it, but how that then applies to being able to provide assessment and care for pediatric behavioral health concerns. We'll share with you some of the history of and the development of the role of child psychiatry access programs. And then we'll share with you what some of our core offerings are for COPCAP, as well as some of the data that we've gathered together. And then really want to help have a conversation, a very robust conversation, and we're saving time for everyone to share their ideas and thoughts as well. And I'm sure Renzi would really appreciate hearing from each of you from your own thoughts and ideas. Can you guys hear me okay? Okay. So general schedule, I'm going to give you the overview of the development of child psychiatry access programs with focus on COPCAP, and Jeanne will describe her experience as a pediatrician working with COPCAP and receiving COPCAP supports and that discussion. In the spirit of full disclosure though, I trained in the triple board program. So I trained as a pediatrician, general psychiatrist, and child psychiatrist, and then have worked at the forefront of that bridging between those areas. I trained at Brown, and we received something called Collaborative Office Rounds Grant, where we worked with early career pediatricians when I was still in training. And that was so cool and so fun that when I left Brown, I wrote it into my contract to do it other places. Sometimes it worked, sometimes it didn't, but I was at North Shore Medical Center in Salem, Mass, doing collaborative office rounds when the very first child psychiatry access program got started, MCPAP, the Massachusetts Child Psychiatry Access Program. I then spent time up in Maine and started a program up there. So I've been part of starting these programs in 3 different states. And Jeanne was also in Massachusetts when MCPAP got started. I will say that Maine and Colorado share a lot in common in that, and I want to learn from you if this is also true in Hawaii, that there's almost a libertarian live free or die approach, the New Hampshire state model, live free or die, where local control is really prominent and the belief that if you're not in our community, if you don't walk in our shoes, and in Maine, they use the phrase, you're from away, so you don't understand. So creating these partnerships always has to be taken into consideration for some of that as well. So pediatric mental health care crisis. There was a pediatric pandemic for behavioral health before COVID-19, but the hospital where I work at, Children's Hospital Colorado, declared the youth mental health crisis emergency in May of 2020. That they were the first to do that, and that my core place of employment is at Children's Hospital Colorado. I do other stuff besides CopCap there. And strategically, it was a good thing because by being the first, you then have to put your money where your mouth is. And so we've actually had some advantages and opportunities to that from that standpoint. By October of 2020, the American Academy of Pediatrics, the American Academy of Child and Adolescent Psychiatry, and the Children's Hospital Association joined together to declare a national emergency in child mental health. You guys, and I'll get into a little bit of what was published in April before the Maui fires about the mental health crisis in Hawaii worsening with physician psychiatrist shortage taking a heavy toll on kids. We can't be here without acknowledging the heavy toll that we know that traumas and disasters such as wildfires will play on everyone in the community. So looking at Honolulu's civil beat, I don't know the paper, but that this was published in April of 2023, that Hawaii is only meeting 14% of the need for mental health. That means that 14 from 100, that would mean 86% of the mental health needs are not being met. And having been in the opening plenary, this is worse than what they were talking about there from that standpoint. Child psychiatry resources, there are not enough. This is looking at counties. This is something that is workforce maps are put out by my professional organization, ACAP, the American Academy of Child and Adolescent Psychiatry, and based on the colors. So if you've got green, it means that there's enough. If you've got yellow, it's a high shortage. And if you've got red, it means no child and adolescent psychiatrists exist. Unfortunately, we don't have similar maps for child psychologists and social workers, but I'm sure that that follows along with that. It can take up to 9 months for an appointment with a child mental health provider in Hawaii. This was before the fires. And there's long waits for all child health, behavioral health providers. Is that something you all experience as well? Yeah. So how are Colorado and Hawaii similar? Now, I'm actually a water person, so I prefer to be around water. I'm not a mountain person, but you guys have mountains also. So I guess we could say that's similar. But this is the workforce shortage map for Colorado. Colorado has 64 counties. 47 out of 64 counties don't have any child and adolescent psychiatrists. You can see the red counties where there's 0. You can see the severe shortage in the kind of orange color, high shortage in the kind of yellow color. So there are not enough insufficient child and adolescent psychiatrists. There's the other thing that is happening that was alluded to in the plenary also is we're an old group of folks, and being older, there's risk in there as well with retirement and people leaving. And so, anyways, so severe workforce shortage issues. The other thing that I think Hawaii and Colorado share is the notion of rural health. And we also use the phrase frontier. So if you look at Colorado here, this is kind of the frontier lands where, it's kind of like where where there's tornadoes and not a lot of people and farmland and stuff like that. But 47 out of 64 counties are rural or frontier. We also have land mass that contributes in many ways, a mountain range going through and isolating on the western slope compared to the eastern side is probably somewhat similar to the bodies of water for the islands in Hawaii. And being able to deliver care in rural areas when no one exists there means that you need to come up with some creative solutions from that standpoint. And Renzi, these slides are going to be available to people, aren't they? Okay. Because I noticed people are taking pictures of them. So let's talk a little bit about what I know about facts on youth mental health in Colorado. So unfortunately, this is not a statistic you want to
I
have.
just joined the pediatric
Suicide's the leading
one.
cause of death from 10 to
I just
19-year-olds.
got on.
You want it to be accidents as the leading cause of death, not suicide. You may be aware of this, but half of all mental health conditions occur before the age of 14. We have a lot of initiatives that say you hit 12 years old, we're going to do PHQ-9 testing, but you're missing out on all of those youth who are preschoolers and school-age kids who are suffering. 44% of teens have been recently reported as feeling persistently sad and hopeless. And so your Hawaii news article said 14% were getting care. Colorado was 22% were receiving professional care. So we're both in pretty grim circumstances regardless. So the child mental health pandemic predated the COVID-19 pandemic. This is from a Washington Post article that was reporting on the CDC report, and this came out in March of 2022. So if you can see, this goes from 2021, 2019, and 2009. So you can see there was so this is the gray is 21, the orange is 2019, and the blue is 2009. So you can see this was even before the pandemic is what was going on. That was persistent sadness, considering suicide, and reported suicide attempts. So we have workforce shortages. People are not getting identified and getting the care that they need. We have rising rates of depression, anxiety, and suicide. We have limited training of pediatric primary care providers to assess and treat. Those are physicians, those are nurse practitioners, those are PAs. There's not enough training to be able to do it at the primary care level. I will also throw out there, what is the impact of digital technology, increased screen time on healthy or not so healthy lifestyle? We're seeing, going along with screen time use, also increased weight. When I was in Maine, it was recognized that the sun never rose high enough to be able to have adequate vitamin D levels. I have found lower vitamin D levels in Colorado than I've seen in Maine, and I'm not sure how much of that's related to screen time as well. So this is from a JAMA Pediatrics article that was published in March of 2022. And if you look here, anxiety is the most prominent mental health condition in kids. And from 2016 to 2020, predating the pandemic, it was going up. Behavioral and conduct problems, high. We got depression is lower than that. So, I mean, one of my missions with COPCAP is to be able to identify and treat anxiety and disruptive behavior problems in youth as well. Because I think there's tremendous opportunities there that may then offset the comorbidity that you're seeing in the teenage years. So I've talked about COPCAP. What is it? It's a lengthy acronym, the Colorado Pediatric Psychiatry Consultation and Access Program. Everyone needs an acronym, and this is what ours ended up being. So I mentioned Massachusetts had the very first child psychiatry access program. It was started in roughly 2004. And then a number of other states followed. So I happened to be in Massachusetts when it got started. And then other states followed, including New York, Washington, Pennsylvania, Maine, and some other ones as well. Because of the work that was happening, and because there was actually data that showed in states where there were child psychiatry access programs, access to care improved, we, as a group, I'm a member of the National Network of Child Psychiatry Access Programs, worked to have it written into the 21st Century Cures Act for grants to promote integration with pediatric primary care throughout, and it originally authorized $9 million. Once the budget got funded for the 21st Century Cures Act, and you all have experienced other things with the 21st Century Cures Act because it's a very long act, including open notes and things like that. But the HRSA, the Health Resource Services Administration, became the grantor through for forming these pediatric mental health care access programs. The very first round of funding came through in 2018, and we were part of the first round of funding. Alongside that, there's also been screening and treatment for maternal depression and related behavioral disorders, much fewer ones for those that have happened. And this is a little bit of an old map, but the other thing that happened was as the pandemic was going through, a lot of money was starting to be brought into HRSA for further programs. So there's a lot more in place now. Renzi, when was Hawaii first funded?
2021.
2021, great. So what are the core requirements to be a pediatric mental health care access program? So originally, all the funding had to go through the maternal Title V programs in the states. That's now changed. You have to be a state entity, but it doesn't have to be Title V. You're required to have an advisory committee. And most advisory committees try to get key stakeholders or people who can help promote the programs throughout the state. You're required to conduct a needs assessment. And then because it's federal money, there's a lot of reporting requirements that have to happen that actually go right back to Congress where they have to report out about that. The core feature was, how do you enhance current telehealth services? You have to have a work plan, which describes how you're doing it. You meet with your program officer once a month and you go through your work plan. Are you completing the things you need to know? Lots and lots of evaluation metrics, but the holy grail is really towards sustainability. How can each state somehow become independently funded? Now in Colorado, as we're working on ours, one of our challenges is in Colorado, there's something called TABOR, which is the Taxpayer Bill of Rights, which basically says you can't raise taxes to support new programs. And so as we're trying to work with our state folks on how do we get continued endured funding, it's going to be a little bit of a challenge from that standpoint. You guys have a governor who is a physician, who's been a parent, and mental health issues are bipartisan. And so you might have some opportunities for sustainability if you get yours up and running and have the data to show that it's going well from that standpoint, more so than we do. Although we did get rescue fund monies from the state, which puts us in a pretty good place. So what's the Child Psychiatry Access Program? We've been talking about it. It's a formal program that's been established to be able to receive timely consultation between a primary care provider and a child psychiatrist. So 2004 was a very different landscape through technology at that point in time. So originally it was all phone-based. When I was at North Shore Medical Center, we were using Palm Pilots. Do you guys remember what those were? That's how we were collecting our data, was through a Palm Pilot. So the digital resources and changes of contact, I've heard people talk about e-consults. I actually, from a behavioral health standpoint, I have to do e-consults, and it's easier just to talk on the phone than it is to do all of that part of it. But I'm digressing. But we've got other different, the digital landscape is very different. So a lot of programs create materials and supports for the primary care providers as well, e-consults, or even just putting your question in through a secure HIPAA compliant portal from that standpoint. Programs were also supposed to help support identifying resources in the community. And then education. Most programs have had education as a core tenet of their identity. And that now occurs through multiple venues. When I was in Maine, I had quarterly lunch and learns with all the different enrolled providers and practices we had. I actually wanted to do, I moved to Colorado in 2016. I wanted, so between 2009 and 2016, I was running my Maine Child Psychiatry Access Program. And we had Norway, Maine, which was pretty far from the Portland area. I wanted to be able to do GoToMeeting for their quarterly lunch and learns. And the pediatricians told me, they said, we're so busy. If we have to stop what we're doing to go behind a computer, we won't do it. But if you show up, it would be impolite not to meet with you. So at that point in time, we were not able to convert to GoToMeeting. I think the pandemic has brought on board virtual learning, Zoom technology, and everything like that. So we've changed, and we can provide that kind of education in those venues now. And COPCAP, in fact, has an annual learning collaborative, which has always been done virtually due to the pandemic. It started in 2020. We started our first Echo series in March of 2020, and then we provide a lot of digital materials as well. And Jeanne will speak a little bit about what it's like as an end user to receive a consult. So our core components, so this is our website, and you can see on our website, we have a resource page, and within the resource page has screening tools that are free and public domain. We've also created Colorado care guides on assessment and treatment of anxiety, depression, ADHD, and action management plans like primary care is familiar with. So we have an advisory committee. In fact, our next advisory committee meeting is on Monday. We train our child and adolescent psychiatrists on how to do this work. And then we also have we work on fidelity measures from that standpoint. We have a formal practice enrollment. That's really important for building relationships so that you can learn to know and understand who each other are. We do provide peer-to-peer consultation. Our benchmark, we can't do it in real time because that would mean we'd have to have staffing with availability to pick up the phone Monday through Friday, 9 to 5, and our resources are somewhat limited as well. But our benchmark is we will call you back within 30 to 45 minutes per your time that you want. Most people want to be called back at a lunchtime, or they look at their schedule and they know what their break is. Or if they've got someone coming in that they need to talk to you beforehand, they'll make that request to be able to do that. When I was in Maine, I had 0.15 of my FTE was part of running my Maine Child Psychiatry Access Program. And I would do other things. And because everyone would defer it. I had an outpatient in my office and the door gets knocked on, and I'm a child psychiatrist. It's like, you're not interruptible. It's that sacrosanct 50-minute hour. You're not supposed to be doing that. And I walk out and my clinical care coordinator said to me, Dr. So-and-so needs to talk to you before a certain time because a patient's coming in and they really need to go through the options before that. I said, okay. And I went back in to see my patient. I said, I'm so sorry. I'm so sorry we were interrupted. And the mom said, that's okay. Because we know if we need to reach you, we can get you. So I think we can learn a lot on how we need to shift how we do things from a mental health standpoint also. We are payer blind. We cover ages 0 to 25. We also are really trying to promote perinatal screening for all caregivers in the perinatal visits. And if there are concerns, we will cover that as well. We work on resource identification and we have free education, ECHOs, the Adult Learning Collaborative. We also then, what we learned from our ECHOs was the value of the ECHO was that people loved connecting with one another. They weren't feeling so isolated and alone. And so we started something we call a community of practice where anybody can join once a month virtually with any questions, or it could just be about how do I do this kind of work? So that was an offshoot of what we had learned from our ECHOs. So this is a little bit of our timeline. So we were funded in October of 2018, but my employer is the University of Colorado. my work site is not at the Title V maternal child health. And so we had to get a subcontract written. It took us 6 months to get that subcontract written. So we had some delays until the subcontract was written. We then, between April and September, spent time on hiring and training program manager, our data manager, our evaluation team, and then building what we needed to build. What was our logo going to be like? What was our model of care going to be? So that required a lot of work. We then trained the first child psychiatrist doing this in early September of 2019, and we enrolled our first practice on September 7th, 2019. We did our first Echo series in March of 2020. And I said, we should not do this. There's this pandemic going on. And everyone else said, no, 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 you should. Because what we didn't realize was with the lockdown, pediatric primary care providers stopped doing well-child visits. So their schedules were less. And because of the lockdown, there was less infectious disease coming in. So they had time to be active learners in that. So they were right, I was wrong. And it's really important to listen to who you work with. And we then ended up doing our first annual learning collaborative in September of 2020 virtually. We started our first community practice after we learned from the echoes in June of 2021. Now we've completed 21 echo series, 3 annual learning collaboratives. We've enrolled 82 practices for more than 805 providers, and we've provided more than 2,400 peer-to-peer consultations. So when you build it and you continue to work on it, it can grow and come. So Renzi wanted me to talk a little bit about how do we train folks to do this work, because you can't just kind of go in blind to do it. I was fortunate that that had always been part of my career trajectory with doing collaborative office rounds and being trained as a pediatrician as well. So CCC or CCN are clinical care coordinators or clinical care navigators. They're the people who are the first point of contact. So customer service is absolutely essential. So we have secret shoppers. We check to find out, how did it go? Were they responsive? Did they answer the phone in time? And we build that into our onboarding training. We have to train about data management. It's really important to collect the data to then make the case for sustainability, as well as how do you find resources and how do you keep, unfortunately, you get a resource and then it's almost frequently outdated. So how do you go through and make sure that you're always checking for that? For our child psychiatrists, our training includes knowledge about the program. Also, data management. I had one of our child psychiatrists that, you know, we all have our challenges, and her challenge was documentation. I found out that this person had not completed filling out the data forms for like 6 months. Oh yeah. Needless to say, I was quite red in the face, and a corrective action plan got put in place, and that person now has to report out every week that they've completed all of their stuff. But we need that data. Data is really important. And we also have, so we go through, how do you fill out our data forms? We use something called REDCap, a REDCap database, because it's HIPAA compliant and it's also free because we get it through the university. There are programs that you can buy, data management programs from that standpoint. But what's really neat is our data manager is also our child psychologist, who's also our website guru. So we were able to capitalize on a lot of his different strengths. And we have a monthly meeting with the child psychiatrist, and we can actually make changes in REDCap at that meeting per request, which is really quite nice. We also have them practice doing a consult, and Jeanne has served as the pediatrician who is like, you know, I'm really busy right now, you know, and I got to get to it. And, you know, we prompt when she's supposed to be annoyed and stuff like that. So thank you, Jeanne. And we also, at our monthly meetings, we review cases for inter-rater reliability, because it's really important that we want to make sure evidence-based care is being recommended and that there's inter-rater reliability. So what happens is the call can come in, it can come in via email, it can come in via e-consult. You don't have to be an enrolled provider. Anybody, you have to be from the state of Colorado, but anybody can call from the state of Colorado. We say if you're going to email us, do not put patient information in there unless it's HIPAA compliant, or you can use a secure platform. We determine if it's a new or patient we've already had in the system. The clinical care coordinator then screens. What is it that you're looking for? If they're looking for resources, it might stay right with the clinical care coordinator. If they're looking to talk to a child and adolescent psychiatrist, then we have a schedule. So that person is alerted to that. They complete it. They might say, oh, you need more resources, and get it back that way. We also have our data manager, website manager, child psychologist, integrated care clinician who serves multiple hats. If we're working with integrated practices and they've got a question for our child psychologist, he will do that as well. We also will offer a one-time only person, face-to-face, it could be virtual or it could be in-person consultation of the patient to guide care back into primary care. That would mean that the primary care provider might be saying, I need some diagnostic clarity, or I have a family that doesn't really, we need a second opinion before they're going to engage in a course of care. So that's what we will do from that standpoint. Oops. These are some of the cases that we've gone through for inter-rater reliability. So, and I think I put them all, there's more than you should have, but I wanted to show you the complexity of what primary care is calling about. So first one, a 19-year-old's medications. Patient was having side effects with Cymbalta, and the primary care wanted to know if there are any other medications with less side effects. You know, Colorado being the first state to recreational use of cannabis, 18-year-old's depression, uses THC, concerned about possible side effects and interactions. Then a 12-year-old with PTSD, aggressive behavior, taking amantadine, which is not evidence-based, I'd like to say. It's not working well. The patient's psychiatrist had recommended a trial of trileptal, again, not evidence-based, and would like guidance with starting the dose. There's somebody in Texas who talks about cerebral dysrhythmia and has this whole plan for amantadine, trileptal, and I can't remember what the third medication is, but it's we have to undo a lot of that as well. And then, I mean, it can get to the level of the bottom one, medication guidance for an 11-year-old who had been in custody of mother in Florida, who was abusive, diagnosed in Florida with bipolar, schizoaffective, depression, ADHD. This landed in the primary care provider's office. Father and father's fiancé have legal guardianship on Geodon and clonidine, never tried on an SSRI. Patient reports she hears voices, sees figures. PCP believes it might be a coping mechanism. Father doesn't want the patient on any kind of medications. So we talk about these cases amongst the child psychiatrists to say, how would each of you handle it? Because we want to make sure that we're talking about this level of complexity and looking for inter-rater reliability. The other thing in Colorado, we have worked to engage school-based health centers. And that's for school-based health centers who are doing primary care in the school-based health center settings. And these are some examples of what might come out of a school-based health center. Provider calls for medication advice, diagnosis of ADHD, now has suicidal ideation. Mom refuses to put the patient on any medication. Another one, and these are often in very rural areas, like guidance regarding medications who had been inpatient. The medications mom has the patient taking differ from discharge paperwork. And then to the provider thinking a patient might have bipolar, possible manic episode. What's the best path forward? So the level of complexity our primary care providers are trying to do this work is really powerful and intense. From an education standpoint, I personally believe each point of contact is an educational opportunity. Those peer-to-peer consultations, we have had people say it leads to a cascade effect. What I learned about that one patient, I apply going forward. So each of those peer-to-peer consultations is a true educational opportunity. As I had mentioned before, we have our formal educational offerings. We have 2 different echoes we offer at the same time. There's 7 sessions each, they're weekly. The first one is Pediatric Psychiatry and Primary Care, core essentials. And then we have a beyond core essentials, and we also have an above and beyond core essentials. And the thing that we added into our echoes, are you guys all familiar what echoes are? I know Echo Hawaii is here. Two things, and that we need to write up because it hasn't been done other places. One is on our panelists, we have a parent panelist, because oftentimes the primary care providers are saying, how do I talk to a parent about this recommendation? So we have parents who are sitting in on our echoes who are part of a program called Parent to Parent, which is a lived experience group. The other thing we added in was self-care. We start every session with a battery exercise. What color is your battery today? Green, yellow, orange, red. Do you have a strategy to get into green? That just taking pause at that moment has been really helpful for folks, because we've seen tremendous attrition in our primary care providers as well. Our annual learning collaborative, we do formal enrollment meetings with the opportunity for education there, and then we have our lunch and learns. So again, some of our core tenets, every point of contact is a learning opportunity. We see ourselves as a program that we want to continuously learn and improve, and try to employ different quality improvement activities. People who work with young folks are generally dedicated and fun, and you can join together, and which is always nice. It's really important to celebrate successes and build on each team member's strengths. Who would have thought that when Ryan was hired as our child psychologist, he would also be our webmaster and our data manager and all of that. So our ultimate goals are to improve access to child mental health care for a statewide telehealth consultation service. I believe we're doing that. Serve as a central place of training for primary care providers, provide in-person or telehealth consultation to guide care, support the identification of local resources, but ultimately to change those numbers that I've shared with you about the rising rates. If we can get disruptive behaviors and anxiety recognized in the 4, 5, and 6-year-old, maybe we can really change some of those trajectories. So I'm going to hand it over to Jeanne to talk about what her experience has been. Well, you made that kind of cool. Yeah.
So thanks for the opportunity to talk about my experience with COPCAP today. I just wanted to share, I'm a pediatrician, and I'm going to talk about how I use COPCAP, but also I'm part of the evaluation team, so I'll share briefly some data that we've done. My background, every pediatrician has a unique background, I think, but I've been in primary care for about 12 of my 20 years in practice. I also did some inpatient years, but most of it's been in primary care or other types of outpatient care. I'm trained in health services research, which gives me the opportunity to be on the COPCAP evaluation team. But currently, my current practice, and I practice 3 days a week at a hospital-based complex care clinic within our children's hospital. It serves kids in Denver and also the areas beyond Denver, mostly in Colorado, though. We do have an integrated behavioral health team there. We have, it's mostly composed of psychologists, and we have a social worker. We have 11 providers in our clinic, and so the integrated behavioral health team is also very busy. So they are definitely a support, but sometimes limited as well. And we also have a pharmacist who answers a lot of pharmacology questions. So you might think, with all of those resources, why would I ever call COPCAP? I seem to be flush with resources, but I do call them fairly frequently because, you know, the integrated behavioral health professionals don't do medication management, and our pharmacy person doesn't sometimes know those subtle clinical nuances that guide one decision over another. And sometimes it's just helpful. I know the patient better, and I know their medical background better because we take care of children with complexity and disabilities. So I feel like in some ways I'm a little bit better positioned to make some of these decisions, but I still need the assistance of a child psychiatrist who can help me with my thinking. But anyway, so or just like 3 general categories of patients that I call for. So we see a lot of kids with neurodevelopmental differences, and it's hard to figure out what's a mental health symptom and what is sort of like part of their genetic syndrome sometimes. We have kids with physical health problems like transplants and who are on other sort of like complex medication regimens, and it's hard to know where to put their mental health concerns within that context. And we do see healthy siblings with mental health concerns, and within this group within this population of patients, there is often an overlay of trauma. So sometimes there's a traumatic event that causes the child's disability and the complexity, and that's why they're in our clinic, and that's affecting the whole family. But then there's also an element of medical trauma too. So the second column is a little bit about why I call. So specifically, there's like just confusing symptoms and side effects that are difficult for me to suss out. Like I said, the physical health problems often interfere with the mental health treatment in a variety of ways. And also there's like, sometimes there's barriers to optimal care. So the guidelines do lay out what the care should be. But for a variety of reasons, either the family doesn't want to go to therapy, or they don't want medication, or it's too expensive, one or the other is too expensive or just not available. You have to come up with some sort of like plan B or care plan that's not quite optimal. And I feel like talking with a child psychiatrist can sometimes make you feel better about that inadequate plan in a little bit, but also try to help you with those decisions. And then also, the treatments, first-line treatments don't always work. And after you get past that, it gets to be a little bit more complex. And I certainly need help with that aspect of it. So this is a little bit about how the practice has changed, both with the COP-CAP being in place, but also there are some other forces that caused us as a practice, but me also as a provider, to up my game in terms of mental health. So we started getting reimbursed for more screening, which is very helpful, but then you detect more cases. So that leads to just more mental health care in the practice. I do feel like as a result of like doing more mental health and talking with the child psychiatrist from COP-CAP, I am better able to articulate what the psychotherapeutic options are. So within the ECHO sessions, and there's guidance on the website around like what exactly is therapy, so I can guide my patients through what to expect with therapy, and also be able to tell when a patient describes what their therapist and they are doing, I'm able to tell whether this is like an evidence-based therapy or something that's not particularly evidence-based, which I think is helpful in me managing the whole condition. Because of COP-CAP, I feel more empowered to usher my patients through more treatment trials. So if the first line treatment doesn't work, I have the tools to do a second line or even a third line treatment, or to add on adjunct medication with some confidence. COP-CAP has a really nice website where they go through the different conditions, and there's like flowcharts and other treatment algorithms that are very helpful. And I feel like for those patients that fall under that, the care I give is more guideline adherent, because I can make better decisions. So all of this translates into sort of like a difference in sort of like how I feel. So part of the mission of COP-CAP is to enable pediatricians and other primary care providers to manage most mild to moderate mental health conditions themselves with the supports of the program. And so I do have that as my sort of like part of my core identity now. I feel more confident in in the decisions that I make. I feel like I have a more solid framework for approaching mental health. I definitely feel more supported, both in my own angst and my own insecurities about doing this care that I wasn't necessarily trained super well to do, but also just in the decisions that I'm making. I feel better prepared for when mental health concerns come out of the blue, and I am actually getting faster and more efficient at it, so that it becomes less of like, I feel like less of a Pandora's box when those concerns come up. I feel like I am taking care of things in a more efficient manner. There are many challenges to mental health care, even with COP-CAP in place and even with the supports of my practice in place. So COP-CAP does not alleviate the larger specialty for workforce shortage. They keep a very nice list of resources for psychotherapy. And so sometimes they know about resources that you don't. And so that can be very helpful, but they cannot create therapy where therapy does not exist. And they can't solve the medication shortages. They can help you strategize around them, but they can't make them go away. The other thing, and I know everybody knows this, patients don't get better quickly, which can be a source of frustration and angst. Also, the more complex cases that I'm taking on, I find that it's harder to lift that symptom burden. The treatments don't work as well for the complex cases as they do for the simpler ones. I think as a primary care provider, I'm constantly in a state of imposter syndrome and always asking, is my patient failing because I'm failing or not? And so talking with a child psychiatrist through all of that is reassuring that I'm doing the most for my patients that I can do. There's also a level of stigma that continues to be prevalent, especially in some communities. I feel like my patients are always fine talking to me about their mental health problems, but they won't talk to anyone else about them, which is a source of flattery. It's kind of flattering, but it's also very frustrating at the same time. I feel like having COP-CAP as a resource and me being able to say to my patient, oh, let me just check with a psychiatrist about what to do here. I feel like they trust my decisions better and more. They trust my decisions more. And even though they're reluctant to enter treatment, it helps me create a care plan with that limitation in place. Mental health takes so much time. It takes so much time. And there are probably instances where my patients have to go to either the ED or urgent care for some care that I'm not able to provide. And I know, especially last winter, which was very taxing from a respiratory standpoint, you just can't provide all the care that you want to do. I think I've invested enough so that now I'm seeing kind of like the payoff of all of this with greater efficiency, and I can do more in a faster amount of time, in a quicker amount of time than I could before. But it is an investment, and there's no creating time because it's finite. So I want to pivot here and talk more about some of the work we've done around investigating how pediatricians and other primary care providers make the decision to use a program like COP-CAP. I think there have to be lots of things in place in order to make that decision to be attractive, I guess you would say. So from the larger environment standpoint, certainly the higher prevalence of mental health conditions with the greater workforce shortage, the perceived need is definitely there. In terms of practice environment, I think there has to be a sense within the practice that this is important, and the policies of the practice are going to support this work for all of the practitioners. I think that it's very difficult to be the one person in your practice who thinks that upping the mental health game is a priority. As an individual provider, I feel like I have an identity now that I am a mental health provider. I do manage or try to manage most of the mild to moderate mental health conditions in my patients. It's personally satisfying most of the time. And so that gives me more motivation to continue this work. But so on that bottom row, the Child Psychiatry Access Program has to be really high quality. So I have to know when I'm calling the program that I'm going to get my question answered. They're going to answer, they're going to call me back when I want them to call me back. They're going to give me advice that's practical and advice that I am able to implement in my practice. They're basically going to be helpful in a very efficient way. I'll talk more on the next slide about implementation, but I think from my perspective, it's important that the psychiatrists in that program know me and I know them. I know relationships are a two-way street, but the relationship with the program is important to me. So just a little bit more on implementation. The calls are one thing and they're important and they're the core of the program, but there are multiple ways that providers can interact with COPCAP. And I think this fills in some of the gaps where that the calls create. So for example, like Sandy was saying, they do practice enrollment meetings where they get to know the practice. Is it big practice, small practice, struggling, more resourced than other practices. I think all of that is just very helpful with the calls in order to tailor the advice to the situation. COPCAP does in-person visits to practices, which I think are very important so that we see each other. We have a lot of promotional events and materials. We have a video that we're working on. We have lots of swag, so like bags and magnets and mints and lip gloss and all that stuff.
The lip balm is the best.
The lip. The COPCAP will keep a list of resources for psychotherapy for all the regions in the state. And I think that is one of the things that they can be helpful with and make my job a little bit easier, is to maintain that list of, you know, who is available, what their wait list looks like, what insurance they take, what types of therapy they provide. All of that is something that I don't particularly want to do. So they do that essentially for us. They have a robust website that is well organized. You can find all the screeners there. They have guidelines. They have materials for families. They have sort of like asthma action planning type things that you can help fill out with for some of the conditions that have sort of like, okay, so you know, this is especially helpful when there's like a long wait for therapy, but it talks about what coping skills your patients can use, how to change your thoughts, how to get out and enjoy nature and connect to the people in your lives. And so I think all of that, it's done like in a 1-page, 2-page kind of thing. And so you can just go through it really quickly with your patients and give them something while they wait for for therapy to open up. We also have echoes and learning collaboratives. I mean, people learn in different ways. They need different types of foundations before they really start doing more of this work. So I think all of that is very helpful in reaching kind of like everybody wherever they are, no matter where they are. All right, so these are some of the data slides, and I'll just go through these fairly quickly. So this is some of the data from Massachusetts, and in Massachusetts, they kind of required you to do the enrollment meeting and then call. And so we looked at, for the practices that did the enrollment meeting, how long it took for them to call. So you can see on the x-axis is the number of months from that enrollment meeting to calling, and on the y-axis, it's the number of practices. And there were 275 practices in this analysis. So basically what this says is most practices called pretty soon after enrolling, after hearing about the program and getting established with the program, most called pretty soon. But then you have practices that called like 1 to 2 years later, even more than 2 years later. I don't know what they were doing in between that time, but they, I guess this is just to say that it's good for the program to have constant contact with primary care providers because you never know when they're going to start calling. But most of the practices that enrolled with the program in Massachusetts eventually did call after 2 years.
Jeanne, you might want to say we've started refreshers because of practice turnover for new folks.
Yeah, that's true. So as you know, people come and go in practices. And so keeping contact with the program from the program's perspective helps ensure that everybody is up to date with all of the programs. All right, so this slide kind of answers the question of like, do providers within a practice call at the same rate, or do they call, like some call a lot and some call just a little? So this graph, if you can imagine, like all of these columns are different doctors within the same practice. So you have Dr. A, Dr. B, Dr. C, Dr. D, And then on the y-axis is the number of calls over a certain amount of time. So basically what this slide is saying is that there is often, this is a pattern that we see, there's often like one person in the practice who calls a lot, and then everybody else kind of calls here and there. So it's hard to say whether Dr. A is overutilizing the service and Dr. G is underutilizing the service. But the point is that there is often one person who is just really into the program. And that person can serve as like a champion. It might be the person who does more mental health than other providers. They might have a more adolescent population, but they can serve as a champion within that practice and kind of bring the whole practice along. So this table depicts what people call about and what happens after the consult, and also the patients that the characteristics of the patients that generate the consults. So about half the consults are for anxiety. I think that makes a lot of sense. Anxiety is a tough one for me, and less so the depression and ADHD. And in this graph, so a lot of calls are about more than one condition because of the high rates of comorbidity. So that's why it adds up to more than 100%. A lot of the calls are about medications. So whether a medication was changed is in over half the calls. The goal of the program is to have patients remain in primary care where they can be in primary care. And for about half of our consults, the decision was to have the patient's care be in primary care. So no plans to send to a psychiatrist, but the primary care provider remains the primary manager of that condition. And then 70% of patients that we receive calls for are severely or moderately ill. So it's a complex population. The percent on Medicaid reflects roughly the percent of kids on Medicaid throughout the state. And 16% of calls are from rural areas, which is probably less than the population, less than what it should be. So here is just some differences between rural and non-rural providers. Basically, rural providers take care of kids with Medicaid or no insurance, more likely to take care of kids with Medicaid or more insurance, which makes a lot of sense. They also call more about psychosis, atypical antipsychotics, and they're more likely to have their patient remain in primary care, which I think the reasons for that are also kind of self-evident. We also looked at whether advanced practice clinicians and physicians were the same or different. And it turns out that advanced practice clinicians take care of a slightly different population, a little older, a little bit more female. They have more Medicaid, more rurality. But the content of their consults is roughly the same. And I mean, I work with a lot of APPs, and I think they do the same level of work that I do, but I think there's a bias out there that they take care of less complicated patients, but we did not see any difference in the complexity of the consults that we received from either group.
It's just an infographic just showing what you've said.
Yeah, this is just a nice, better looking picture of what I just said.
And you can find it on the website.
And now it's time for some discussion, questions.
So we want to hear from you. You're going to be our moderator?
So we have like 10 minutes left if there was any questions from the audience. I know that was a lot of information, and so if any questions. Oh, yes.
Yeah, you don't have to use the QR code.
Yeah, I was just wondering, what percentage, are they full-time psychiatrists working with your group, or do they volunteer, or what is the essence of?
Yeah, so we're paying for FTE, and it's actually, so I use the numbers based on Maine for, like, I was 0.15 FTE taking care of 56,000 kids. So the population in Colorado, for us to fully staff, it would take the equivalent of 2.2 child psychiatrists. Right now, we're running just over 1, but we haven't enrolled all of the practices. So, and we have our FTEs are from are generally you need to be at least 0.2 or 0.3, just so that you know what you're doing. But we've actually just hired 2 specialty providers. One who is a new triple board grad who is going to be available for really, really medically complex as well as neuroatypical youth questions, and then someone with an expertise in substance use disorder. So they will be ad hoc, and we're only paying 0.1 FTE for them.
Yeah, I mean, I guess the dilemma is, as a pediatrician, I became a de facto psychiatrist on the Big Island. We had no one taking new referrals for at least 22 months in the past 2 years.
Yeah.
And so I'm trying to squeeze, with 5 guidelines, the anxiety, the depression, the sports physical, this, all of this data in a 20-minute visit, and then having to bring them back at 4:30 in case they want to stay until 6.
Yeah.
I've done all my ADD itself. So I'm just wondering, can this actually help? Because I mean, I know kind of most of the thing because I worked in autism before I went to med school, but I feel like having telemedicine, a telemedicine system within the community where people could see the psychiatrist, because they don't want me to start their kids' lithium. They want a psychiatrist, but there are none, or there are no providers. Is that ever in the works with this? Where the psychiatrists are doing telemed visits with patients other than the one visit?
So that doesn't help with the workforce shortage challenges. So it's really about how do you parse out who should be reserved for the highly specialty. So I actually got a call back when I was in Massachusetts from a pediatrician on North Shore Medical Center and called me about a late teen who sounded like he was hypomanic. And I said to him, you don't have to take care of him, send him to us where I was working. He goes, I know this family, they won't go. They will only work with me. And I said, well, let's talk about what you feel comfortable with. I bet you don't feel comfortable with lithium. He goes, no, I don't. I said, well, I bet you've had a lot of experience with Depakote. Can we start there? So finding that happy medium also, I think, is really important. And I don't know, Jeanne, you also have had a lot of background experience.
Yeah, so I think where it can be helpful is when you know you're going to have a wait to see a psychiatrist, but you want to start something in the meantime, or maybe, because it's going to be months before they get in. So I think starting something, even if it is as high level as lithium, which I agree is outside of the purview of primary care, with a psychiatrist backing you up, and they can they can talk about the same patient, like every 2 months for you while you wait to get into a psychiatrist. But I think that's where it's helpful and necessary. Like, there's just no other alternative if there isn't a psychiatrist to be had.
He was in line.
So logistically, so for the ones that are either getting worse or, going too slow, logistically, does the Copcat psychiatrist take over, or are you able to find, especially with those rural areas that don't have psychiatrists, how does that work?
Yeah. I will say telepsychiatry has helped in that it's helped build some of those increased access. The problem in Colorado, though, and it might be true here, is broadband access. So very rural areas are really challenged with broadband access. Colorado is also really messed up with respect to its levels of care and how it's delivered throughout the state. And so the crisis services vary from county to county, area to area. And so oftentimes we just have to really work with the primary care folks as to what, and then find out what other resources are available to really try to help offset that. But as Jeannie said also, we want to be able to co-manage along with you through support and hearing. And so for some of the cases, they actually get co-managed over time as well.
Thank you for the opportunity to ask. I was just curious. We just passed the bill. It's Act 192. It's a 3-year pilot program, and I've seen the anxiety, depression, suicidality, and everything. I was kind of wondering whether or not have you encountered or have you worked with fetal alcohol spectrum disorders, because they're kind of the invisible disability. They have a lot of behavioral and a lot of challenges, and I'm one of the advocates for that. And how can we tap into these resources for that population?
Yeah, so we do see kids with fetal alcohol syndrome, certainly in the practice that we have at the hospital.
You're talking about your pediatric specialty care clinic practice
Yeah.
as a pediatrician,
As a
not
pediatrician.
COPCAP.
Yeah, yes. So sorry. Yeah, so within that population, you're right, there are challenging behaviors, and a lot of them need medications to help with those behaviors, as well as specialized therapies. I think COPCAP can help you manage some of those challenging questions and take the care as far as you can while you're waiting to get into a psychiatrist, or for those more mild cases instead of going to a psychiatrist.
And I would also say that, we're really delighted that we've hired these 2 other folks for ad hoc care and support. And the recent triple board grad is really taking on availability for neuroatypical youth and youth that have genetic inherited things. The other thing, we operate through Children's Hospital of Colorado, and we're very fortunate. We have 2 psychiatric pharmacists who we're going to start buying out time for them also to be part of the service. So trying to leverage whatever resources you have to do that is really also helpful as well. So these 2 individuals are just incredible to help support us there as well. So we might even have our child psychiatrist reach out to the pharmacist before calling back the primary care provider as well, so that they can be really wrapped around for these complex kids. Yeah.
Thank you for your presentation. I think it's just a fascinating concept that hopefully we can work out something in Hawaii. So I just wanted to make a comment. I'm a pediatrician from Hilo, like Dr. Walco. And some of the challenges we face is, and this is really at the grassroots level, how do you actually incorporate a program like this we have to do all the well child care. We have to do our own dermatology, infectious disease, neurology, everything else.
Yeah.
How do we work this into our workflow? How do we actually get a payment for it? Because as you know, and I'm not sure if you know, but we have a certain type of almost a capitation system here where we're not able to bill for anything specialized, and especially something that's very time consuming. So how do we work that through as the pediatricians?
Well, you're absolutely, those are like several questions within there. I will say that advocacy towards getting reimbursement for health and behavior codes in primary care is something that you as an organization should think in terms of for that standpoint. Busy schedules, I would hope that as the program here gets started, practice transformation, best practices would be helpful. That's one of the reasons why we have our community of practice. Also, people are getting support from one another on how to do those kinds of things. Also, go to our website, www.coppcap.org. Go to the resources and look at the Colorado Care Guides, because those are really designed to help do some of that work in primary care as well. I would also really urge, as your program's getting started, to have that family voice in there as well, because I think families can also guide practices for how to make some of that practice transformation.
Yeah, there are just some things that I've don't do. Like I don't get out to all of the topics during well-child visits. You know, I probably do more home care for like respiratory illnesses than what I should. You just can't do it all.
The other thing that I was concerned about, but we left it early, the plenary, I don't know if they got to mental health parity or not, but that's another huge advocacy initiative that needs to happen because at a national level, it's not worked well at all. So, yeah.
Thank you.
So we're getting the notice that we're at time, but if you want to keep staying and asking questions, we're happy to stay.
Sorry, not a question. I just wanted to, because we had two Big Island doctors raise this question. So we're in Oahu and we have about 30, 35 pediatricians in our group. Same problems, even with access to some behavioral health. So we started a program with 2 social workers, and now we're up to about 20 that basically offload a lot of that burden from our pediatricians. And when they have a child with special needs or challenge, they immediately refer to this team so they can do the assessment, the intake, work with the families, identify the needs, and then we work with the pediatrician to get them connected. So
Yeah, I mean,
just,
integrated
yeah.
health providers and true and integrated care models can be
Yeah.
really helpful. There's also collaborative care models that look at how do you manage a population with a diagnosis as well. And there's some formal programs for that as
Yeah.
well. So.
Yeah, there's also, you know, looking at the things that you do, all the patient care tasks that are on your plate. There might be some things that like your nurses could do or other staff can do. I think if you have like a whole practice sense that you have to do this mental health care and it's going to be time consuming and everybody has to pitch in, they will step up to the plate. I think everybody has like a family member or some good friend with a mental health condition. And so everybody's like kind of sympathetic to that aspect to it. So I think kind of like creating a mental health friendly environment to your practice is also helpful.
And as you're thinking about longer term advocacy, are you guys reimbursed for behavioral health screening in primary care? Because if you're not, you should be for socio-emotional visits at well-child visits. That's part of EPSDT if you take Medicaid. So that might be another advocacy route to make sure. I mean, it's only like $16, but it's still $16, which can be helpful. Yeah, for a screening tool. Yeah.
And I think that's it for time, but our booth will be around and we'll be around. So if there's any additional questions or conversations regarding this, please feel free to come. But thank you again, Dr. Fritsch and Dr. Van Cleave. Thank you. And thank you all for coming to the presentation.
Was this helpful to learn about? Okay, good.
Stressful.
Yeah.